This is going to be our only meeting before the council AGM, so the intention is to try to scrutinise how adult services are responding to the COVID crisis and the pandemic. Just some housekeeping announcements. If you wish to speak, please use the hand or the messaging facility, and this is being recorded. It's not being broadcast live. It will be put up on the website after the meeting. So treat it as live, I think, is the best advice I can give you. So first of all, apologies for absence. We had no apologies, Liz?
No, we haven't received any apologies.
Okay, Liz is going to do a roll call now to invite people to say who's here for the record and for the recording. So Liz, do you want to go through the list?
Yeah, Peter Black.
I'm here.
Mandy Evans.
I'm here.
Joe Hale. No. Chris Holly.
I'm here.
Paxton Hood-Williams.
I'm here.
Yvonne Jardine. No. Jeff Jones.
Yes, here.
Peter Jones.
Yes, I'm here.
Sue Jones.
Yes, I'm here.
Erica Kirshner. No. Hazel Morris. Hazel Morris. I know she's here.
I can see her in the name.
I think she's muted.
Okay. Oh, there she is. I can see her now. Okay. Gloria Tanner. No. Tony Bedo.
Yes, here.
Clive Lloyd.
Here.
Dave House.
Here.
Amy Hawkins.
Here.
Helen St. John.
Here.
Thank you. That's everyone.
Okay, thank you very much. Do we have any disclosures of personal and prejudicial interests? Anybody?
Peter, it's Mandy.
Hi, Mandy.
I'm a member of the Community Health Board.
Okay, Christopher.
My daughter works for social services.
Okay, thank you, everyone. Prohibition of whip votes and declaration of party whips. I doubt if anyone's had a chance to have a meeting to even whip anybody, but anyone want to make any declarations? No? Okay. Right, next item is minutes of previous meetings, which is on pages 1 to 5 of the agenda. So I'm going to go through for accuracy page by page. So page 1, page 2, page 3, page 4, and page 5, which is just my signature as it happens. So, okay, so everyone's happy those are accurate. Lovely. I think someone's got a radio on at the back in the background. Is it possible to mute that or switch off? We will obviously mute everyone anyway. Right. We have no questions from the public at all, so we're going to move straight on to item 6, which is the service-specific update on COVID-19 pandemic. I understand, Dave, you're going to do a presentation by sharing your screen. Is that correct?
Yeah, that's right. I think the cabinet member wants to set the context first.
Okay,
yeah,
Clive.
Right. Say a few words, Chair. First of all, yeah, no, thanks for inviting us to the Scrutiny performance panel today. My first time as in my current role as cabinet member. So yeah, it's been interesting. Thank you very much. An interesting few months, to say the least. Notwithstanding your opening comments about this being the last meeting before the AGM, Chair, I suspect that this will be first of a number of meetings that will take place to look at COVID-19 response from a council context and particularly from a social care perspective. So in my opening comments, I just wanted to position really what we're trying to achieve today. So it's very much about the Swansea Council response, but I think it's worth restating the governance arrangements around that, which will set some context around some of the decision making and some of the actions that Dave is going to outline during his presentation. Now, I think the Chief Executive and the leader attended the Scrutiny Performance Panel and highlighted some of those governance arrangements. But from the outset, the role of us locally was not to come up with guidance. That was very much the role of the Welsh Government and Public Health Wales. But what it was for us to achieve is to implement that guidance to very much the best of our ability. And to do that, we undertook a structure, a governance structure, which is based around a regional approach, a strong regional approach with the Swansea Bay University Health Board and Neath Port Talbot Council. So around that regional planning board footprint. Dave would have attended other emergency meetings through that emergency process, through gold, silver, command type structures, but very much a regional approach. And then locally, we very much had an executive group approach. So that was made up of lead officers within the council and lead politicians, which met for much of the late March, April and May on a twice daily basis over 7 days a week. So really, strong in time guidance and methodology of how we were going to implement that, from a very early stage. So in terms of the key areas that the presentation is going to look at, again, worth restating that, a lot of this, the actions that Dave is going to describe would taking place in time, so not with the benefit of hindsight. So, receiving that guidance and trying to act on it as quickly as possible, and in some cases trying to preempt that guidance as the situation was unfolding. So keeping that very close look on what was happening locally, but on a national basis as well. So the key areas that Dave is going to touch on is about the mobilisation and restructure of the organisation to deal with the pandemic at the very, very early stage. And that unfortunately meant in some areas that we had to look at stopping some of our services as we look to focus on those critical aspects of our service delivery, which we felt was going to be the most affected and require the most attention. So, it did require buy-in from some of our service users around domiciliary care, particularly day services and respite care, that we took the decision that we would have to look to either reduce or stop in some instances to create that extra capacity to support the NHS and hospital discharge, that hospital discharge process, which, as said, Dave will touch on. In the middle of all this, Dave has had to deal with a change in leadership. So Amy and Helen are here today as heads of service. So Alex leaving the organisation, I think at the end of or mid-May, to take up a new post in Carmarthen was beyond our control. But that I just wanted to throw in both a thanks to Alex for all her contribution at the very early stages and until she left the organisation, but also a bit of a baptism of fire for Helen and Amy as they picked up the new heads of service role. And Dave will outline the rationale for creating those two heads of service out of what was formerly a single head of service role. So about creating that link with the NHS and Swansea Bay Health Board. So that's restructuring the internal organisation. At the same time, we were getting guidance at various stages about what types of personal protective equipment would be required within the settings that we were operating in, and that included support of not only our internal care home sector, which given that we made a decision a number of years ago to retain that in-house care offering within the complex care area, where there was a support for the private sector as well, in making sure that they were supported in terms of receiving guidance and appropriate PPE. And again, that extended to testing arrangements, local testing arrangements, which Dave will touch on as well, supporting both our internal care homes, but also the private sector. And I think the support of the private sector has been really important. And I think Dave will outline a good support mechanism, but a good and appreciative exchange from that sector as well in terms of the support that they were given. Just being political for a bit, I'm certainly not in a position of endorsing things like the Prime Minister did about the private sector, about their application of guidance and blaming them for in any way, shape or form. And for any of the things that took place in the care home system in Swansea, and I would hope that the committee would support that rebuttal as well in terms of looking to apportion any sort of blame. So those are the key areas. The last part that Dave is going to touch on is that coronavirus is still with us. It hasn't gone away. We see the relaxing of restrictions on a daily and weekly basis now, don't we? But the virus is still there. And we, Dave and myself and the heads of service have been actively looking at how we can continue to support a structure to tackle a pandemic that's probably going to be with us certainly until a vaccine is delivered, and that will probably take around the next 12 to 18 months. So it's how we're placing ourselves going forward. So that we don't get into a position where we're reacting, but we put ourselves in the best possible place to react to any second wave, any spikes, any localized spikes, working with again, as I say, on a regional basis going forward. And finally, I know that you might want to touch on equally important is the care and well-being of our staff and going forward, because they've been through an immense period, haven't they, in the last 3 months, and any thoughts of a second wave. We have to take this time that we have now to make sure that the staff are well supported, their well-being is looked after, that pastoral support is in place, which all fits in again to part of the restructure. So, Chair, I'll leave it there. I think those are my opening comments, and I'll hand over to Dave now to take us through the presentation.
Thank you, Clive. Dave?
Okay, thanks, Chair. Thanks, Clive. Yeah, I'll try and project the screen now. I won't then be able to see probably people putting their hands up, Chair. So I'll need you to monitor that. If you want me to stop at any stage, just stop me.
I was going to propose, Dave, we take the whole presentation, then we'll do questions afterwards. But okay, I think it's going to be much easier to do it that way.
That's fabulous. Let's hope that I can do this now then. Is the screen projecting yet?
Blank screen.
Right,
yeah.
Okay, hopefully it's coming.
It is there.
See it now?
Yeah, excellent. Yes.
Good. Okay, I'll just set it up to run. Sorry, my computer's a bit slow to react. It is getting there. Okay, hopefully it's working now. Just before I begin, Chair, and to build on that last point that the cabinet member was making, I'd like to. This definitely isn't a political point. I'd just like to place on record as Director of Social Services in Swansea, frankly, our staff, both within the council and within the wider social care sector, and colleagues and partners in the health service, been absolutely extraordinary in their efforts to respond to something that we had no idea what we were facing. and frankly, anything we have asked of our staff, both internally, externally, and colleagues within the Health Board, have absolutely responded to that on each and every occasion. It's been absolutely extraordinary. That's not a political point. That is purely a point of the Director of Social Services reflecting on what's been happening locally and regionally. So I'll place on record my thanks. I'll move into the presentation now. So I'll start first of all with the overall summary of the changes we made in response to COVID. As Cabinet members already acknowledged, one of the first things we did was took a position as a region that it only really made sense in trying to plan our responses if we did that absolutely as a partnership. Made no sense at all if we were making decisions as individual organisations. So we set out explicitly right up front, no, we wanted to do this, things as a partnership. We wanted to make sure that decisions that needed to be made in relation to the health system made sense in terms of social care system and vice versa. Given that we operate as one health board in this area, didn't make sense for one council to do something that might contradict what the other council was doing. So we set that up, stated that explicitly early doors, and we amended our RPB arrangements to coincide with the emergency response type arrangements of silver, gold, etc. So essentially we created a community silver arrangement that fitted in with the wider gold silver infrastructure of different organisations, and that became the mechanism through which we made decisions as an RPB, and it flowed up from that emergency silver or that community silver arrangement, up to chief execs and leaders, etc., fed into the organisations. But that became our COVID RPB arrangement, and that's worked very well to date. Again, as the Cabinet members already touched upon, we did indeed have to deal with Alex moving on, but also it made absolute sense to us. And my suspicion is we'd have been looking at something like this even if Alex had remained. It made sense, particularly in the context of what we were dealing with in relation to COVID, to strengthen our leadership arrangements. One of the ways we could do that was to split the head of service roles. In particular, we wanted to strengthen the integrated arrangements with the health boards, consistent with what I've just talked about in terms of our approach to COVID generally. So we wanted a leadership role particularly focused on the integrated space. But clearly, we also need, there's lots of other stuff that the local authority and the council are more predominantly responsible for, not completely disparate from an integrated space, but more obviously, the local authority needs to take the lead on them. An example might be in-house provision, etc. So we split the roles. I've created 2 heads of service roles. Initially, that's for 6 months. Part of the reason for that was that we wanted to learn lessons from how that worked, but also, given that we were making those decisions at pace necessarily, we wanted an opportunity to reflect. So at the moment, these are 6 months posts with a review ongoing and a commitment that we will come back to the council and come back to the health board with some advice about what's worked, whether we need to make changes, whether both organisations are comfortable that we should progress permanent arrangements, and then we would go to something that would be a more normal recruitment process, given that we were making recruitment decisions in extremis and at pace. Again, as the Cabinet members touched upon, early doors, we need to make some decisions about which of our services we should prioritise. All of our services have needed modification, but some of those services, frankly, made no sense in terms of how you would manage infection overall within the system. And two obvious services that we suspended were our traditional day services and our planned respite arrangements, logic being that they were services which would cause an issue for us in terms of risk of infection transmission, that wasn't proportionate to the actual service that, the service that needed to be offered at this particular point in time. That doesn't mean that individuals who might ordinarily access planned respite or might ordinarily access traditional day services didn't need to be supported additionally and in a different way as an alternative in the interim. But much of what we wanted to do in those circumstances was find ways of supporting individuals at home rather than in more institutionalised settings where it's more difficult to balance that risk of managing infection transmission. So that was the logic there. You might want to return to that after the presentation. We also, obviously, in terms of, again, part of the effort to manage transmission more generally within society, we needed to move more towards home working arrangements wherever possible for the time being. And what that meant for, in particular for our workforce around assessment and supported care planning, that we needed to find ways of carrying out assessments remotely and virtually wherever possible. That doesn't mean that absolutely everything could be done without some level of face-to-face contact, but wherever possible we tried to move to those arrangements. Again, that's worked very well in the at least in the short term. It is different, it's not optimal, it's not something that you would want to maintain forever. But I think for the at least certainly in the initial stages and up until now, I think we've struck the right balance around that, and it's certainly improved our workforce's ability to make use of some of the virtual tools that are available to us. Again, you might want to ask questions about that once we finish the presentation. I've put on here that we needed to extend our out of hours provision. So, for example, early doors at the point where we were certainly having to manage the initial surge, it didn't make sense for us to close our services for bank holiday, for example. So we kept open over bank holidays beyond what usually would be covered by our emergency duty team arrangements. We've had some for a period of time, some extension of weekend working and some enhancement of things like our capacity to deal with mental health assessments out of hours, etc. So we've enhanced some of our emergency duty team arrangements and extended essentially some of our opening hours around particularly bank holidays, but also some weekend stuff for a period of time. I'll return to some of that in terms of the planning for the restructure going forward later on, but for the moment, just to touch upon the fact that we have extended our out of hours provision, and again our workforce have been extraordinary at pace, just finding ways of doing more and working in different ways. That included some of that out of hours working for individuals that wouldn't usually be working in that way. We also, again, early doors, looked to what do we need to do to enhance the resilience of our care provision in-house. And there are a couple of factors to this. It clearly was thinking at the point of, first making judgments about what we'd need to do, or nationally what the guidance was about what we would need to do in order to manage that risk of, or help manage that risk that the health service might become overwhelmed. So one of the arguments was, well, we need to make sure that the social care sector is as resilient as possible. One of the things that's more easily directly within the control of the council is our own in-house provision. Again, early doors, we looked to see what we could do to expand and enhance both our residential and our domiciliary care capacity. There was probably a more significant worry for us, though, about what would happen if the social care sector itself became disastrously impacted, either through infection in care homes, causing problems in care homes, or if the workforce, both internally and externally, was significantly impacted. So it wasn't just about, well, hang on a minute, do we need enhanced provision in social care in order to help mitigate the health service becoming overwhelmed? It was probably more a concern at that stage, what happens if the social care sector itself breaks down because of staffing, because of infection in different settings. So much of our decision making at that point was, well, goodness me, we are going to have to try and mitigate against that eventuality, plan for all eventualities. So we took a decision that we would enhance our in-house provision. We still could face those same difficulties within the in-house provision, but at least we would be able to look our residents and each other in the eye and say, well, we've done everything we can to build that resilience and mitigate against some of those, more disastrous outcomes if we could. That included within that we expanded in particular our intermediate care offer. So our reablement provision, both bedded and community. What that enabled us to do was build on what was already a fairly well advanced hospital to home service, but we had a view that we would need to enhance that would be helpful, that would build resilience, that would help to support more people quickly to be able to return home. And we know that it's safer for everyone if more people are able to be supported at home rather than find themselves unnecessarily in hospital or find themselves for an extended period in more institutionalized settings. Converse of that applies. We also sought to enhance wherever we could our hospital avoidance services. Lots of these services sit within community health. Clearly, we're working closely with health colleagues, but some of that provision, including an element of our in-house domiciliary care provision, for example, or our in-house therapists, etc., are also focused on hospital avoidance. So again, we did whatever we could to enhance that offer across the board. Again, as the Cabinet members touched upon, early doors, we went strong and publicly across the region around the reprioritisation of our offer of care through revised eligibility, which was allowed under the Welsh Government's COVID legislation. We took a position that said, look, it makes no sense for the reasons that I've already described to be supporting people in more institutionalized settings where the risk or the difficulty in managing infection control is more challenging. If we can find ways of supporting people more at home, that would be a sensible thing to do. So we were quite explicit about that. We will be prioritising services and offers of care that support hospital avoidance, the avoidance of residential care. It obviously needed to include prioritisation of any risk of significant harm. And frankly, we were quite explicit about, in the context of COVID, that significant harm is the avoidance of death, given that was what we were concerned about at the beginning. Is that what we would be facing locally and regionally? We also sought within that communication very explicitly with the public and with other stakeholders was that did mean for individuals for whom we could find a different way of supporting them, that we would be reducing and in some cases withdrawing, at least temporarily, the care services that they would be used to, but with an expectation that we would be facilitating conversations with families and others who could step in, at least in the short term, to make sure that people remained safe and well. To a large extent, that was pushing an open door because a lot of people were contacting us saying, we don't want people in and out of our houses. We think we can manage. But it seemed reasonable to us, again, for the reasons that I've just described, that we should be honest and upfront and say that's where we need to prioritise our efforts at the moment, in the same way as hospitals, for example, said, well, for the time being, we're not prioritising, routine operations, etc. We're prioritising our response to COVID and other critical responses. So it was consistent with that approach. And we took that stance as a region. As far as I'm aware, we're the only region that were quite so transparent with our population about that. And even in hindsight, I still believe that was the right thing to do. It was a difficult message, but I think people appreciated our honesty. It did allow for people, and was necessary for people to come back and say, we think you got it wrong, or our circumstances have changed, over time. And then, of course, we would relook at each and all of those circumstances as and when they arose. That hinged upon the council, as opposed to just, adult services or adult services in the health board, having as resilient arrangements in place as we could to support our communities. And in particular, one of the things that we put at the forefront of that revised council offer, working with third sector, etc., and volunteers and communities and ward councillors, etc., was the expansion of local area coordination. So local area coordination was expanded way up over and above the numbers that even full rollout of local area coordination would anticipate in normal times. I'm describing it as local area coordination. It was in many ways it was a different offer of local area coordination, certainly at the height of the initial surge. Local area coordination, as you are well versed in, is a strengths-based, facilitating, putting people in touch with others, reciprocity at the heart of it. Well, there was a lot more direct helping people in the local area coordination, amongst other things that the council did, than would usually be the case. I heard that described a bit as, well, we bent local area coordination out of shape for a period of time, and now we need to bend it back into shape. Otherwise, we lose some of the other benefits of a local area coordination approach. But again, even in hindsight, that was the right thing to do at the point, in the circumstance that we found ourselves, and the feedback that we've had from members of the public and other stakeholders about the work of colleagues in local area coordination and other colleagues across the council, particularly in cultural services, and particularly our partners in the third sector. Again, the feedback I've had has been extraordinary about how valued that work has been. So I pay tribute to all of those staff. Again, the cabinet members touched upon it, but one of the big steps for us was around restructuring of adult services. So you all know that we were always planning to restructure adult services. Work was progressing on different aspects of that: the creation of safeguarding team, dedicated dolls team, enhanced front door, lots of things that we were working on. COVID changed our thinking around some of that, necessarily. And as the cabinet member has said, lots of our thinking now needs to be about how do we make sure we are in the best possible place, structure-wise, resource-wise, services that we offer, to manage a sustained period of COVID being in our communities. Including within that is our ability to respond to any future surges and what's described as super surge. So workers, we've had to make some changes with immediate effects, but alongside that, the new heads of service have been leading planned restructure changes, getting us in a position where we think we'll be fit for purpose going forward, at least for the next 12 to 18 months. We're at a stage now where we've done all of the consultation with unions and with the workforce. We're now working through a period of phased implementation of those planned changes. We'll still, no doubt, some more learning to come during that phased period of implementation, but I'm absolutely confident that we, the thoughtfulness that's gone into those suggested arrangements will leave us well placed as a service to be resilient to what we anticipate we might have to face, either just with COVID being in the community at the sort of levels that we're experiencing now, or should we have a future surge, and in particular I suppose I'm mindful of what might it look like in winter. On top of that, we've obviously had to work hard to support the social care provision in the external sector. A huge amount of care to our residents is commissioned through external care sector, particularly residential care, nursing care and domiciliary care. Again, just to reiterate, the colleagues in the independent sector have been absolutely extraordinary. We are focused on our commissioning support to the sector, our advice around infection control, pastoral support, the supply of PPE, and financial support. Welsh Government have recognised through their hardship fund that there'll be significant financial impact on the independent sector, and have asked local government to provide that financial support and then claim it back from the hardship fund. At the moment, the schemes run up to the end of June. We're not quite sure what the arrangements are going to be going forward. I think there is a recognition from Welsh Government that there does need to continue a scheme as that's been facilitated to date. By the time all of the claims have gone through, my estimate of the level of financial support that will have gone out to the external sector will be something like £3 million extra up to the end of June. It hasn't all gone through the books yet, hasn't all been claimed back yet, but that's our forecast of what we're expecting once all of those claims are worked through. Going to move into some of the specifics now. So personal protective equipment, again, in the we've maintained the same spirit of we will try and do things as a region. So we established regional arrangements for a procurement and distribution of PPE. Swansea have taken the lead on that. That's to supplement the national supply chain. That was particularly important. We took a position early where there was a concern, don't know whether it would have come to fruition, but there was a concern that the national supply arrangements that were implemented when it became obvious that particularly the independent sector, that their usual procurement chains were breaking down. We had a concern that the national arrangements wouldn't kick in quick enough, and we weren't confident in the absence of, all of the information at that point that that will come through quick enough and at particular, the scale that we needed it to. So we took a position as a region that said, well, we will strengthen our own council procurement arrangements and then distribute as a region. That put us in a good place in that we were always able to stay ahead then of the guidance. So the guidance kept changing in relation to the proportionate level of PPE use through a combination of the Welsh Government supply coming through and the efforts that we've made to procure regionally. We always had enough PPE to comply with the guidance, which was good. Clearly, there was difficult discussions at that point about, oh, hang on a minute, if you don't just follow the national arrangement, could you somehow usurp, could that cause a problem elsewhere in the system? That was a consideration. I think it was quickly realised that everybody was relying on the fact that regionally we took steps as well as those national arrangements, at least until the national arrangements got up and running. So even in hindsight, I think that was the right thing to do. We've consistently, Cabinet members right to say it wasn't for us to write guidance, etc. There have been, that's national, policies, etc. Needed to come nationally, and they did. There was a role for us in terms of clarifying and strengthening some of that, and then localizing it for how we would actually implement stuff. So PPE was one of the areas where we've done that. And so again, early doors, we were able to give absolute clarity to both internally and externally around things like the use of PPE, how the distribution arrangements are going to work, etc. I've put here monitor compliance. I don't want to overstate that, so we're not going out. No way we'd be able to go out and police individual care homes, by visiting and checking and using it all properly, etc. But we had constant dialogue with the care homes, and if any concern arose, either raised by the care home itself, or if we had people contacting us saying, why isn't we are expecting people to be using PPE. Our belief is that it would look like this, whatever that might be. We're not experiencing that, and we would check them with those providers. Have you understood the guidance? Are you using it in this way? How you? So we took that very seriously, and did our best to reinforce those messages and make sure people had good advice around those things. From my perspective, vast majority of times we followed stuff up because queries have been raised. Actually, the care homes were, following the advice that we had given them locally and regionally. Usually there was some misunderstanding somewhere else around what actually the guidance said and what the expectations were. Through the arrangements that I've already described, we managed to build up and maintain a surplus stock. That's still the case, because we now need to be thinking forward about what might it look like going forward. There's national debates about the arrangements for PPE going forward. So in this region, we have established a surplus level of stock. It's not, clearly wouldn't last forever, but at least gives us a buffer if we ever face a period where there's a bit of delay between any changes that might happen nationally and what needs to happen locally. My screen is doing funny things. Am I still presenting on screen, Chair?
Yes, you're still presenting on screen. That's fine.
Good. Okay, that's good. And then this final one here, again, could be considered a bit contentious, not contentious. So the way the guidance, guidance was changing all of the time, particularly around PPE and some other aspects. But in relation to PPE, there was a particular set of guidance that said, essentially, you don't move to full use of PPE until there is sustained transmission within communities. Now, that judgment about sustained transmission within communities struck us as a particularly challenging one. At that point in time, things were really difficult in East Wales, weren't quite so difficult here. But nevertheless, we took a position locally and regionally that said, no, we're not waiting for somebody to tell us that there is sustained transmission within the communities. It makes sense to us that, we need to be doing everything we can to make sure we minimise the risk of transmission in this region. So we moved to full use of PPE, and then very soon after that, the advice came out, moved to full use of PPE, and we'd already moved to that. Now, that may only have been a matter of, a week or, at most a fortnight, but we know in hindsight that a week or a fortnight, they are significant periods of time in managing the impact of, of this pandemic. So, again, in hindsight, you might say, I wish we, moved 6 weeks earlier or whatever, but the reality was we moved, ahead of when the national guidance, effectively said that we should have. And again, I'm pleased that we did that. A little bit more about care homes. So a hell of a lot of guidance has come out around care homes throughout the period of the pandemic to date. Literally, wouldn't be far short of 100 different bits of guidance. That may even be an underestimate, all of which clearly needs to find its way into the system for our care homes to adjust to, our commissioners to adjust to, our health and care system to adjust to. Again, early doors, we took a position of establishing a regional care homes protocol that would constantly be updated to reflect and reference changes in the guidance that were emerging. So we established that early doors, have kept that up to date. That has become, very much the Bible for us locally and regionally around how we're supposed to be operating within the care home sector. I think external providers have found that clarity and that one place to go helpful, rather than having to search all over the place or keep responding to different things from all sorts of different organisations, etc. Again, this was another example of us preempting some of the national guidance. It wasn't clear early doors exactly how care homes should be responding to infection. I don't want to overstate that. It was clearly a very difficult period. It was clearly early. Some of the science around what works and doesn't work was emerging at the time. So we took a position at that stage that said, if we are concerned that there is infection in care homes, so not necessarily that we've had positive tests, but if we're worried that we've got evidence of symptomology, whether that's as a result of staff or residents, that our position would be that we would resort to or we would implement full barrier care for all the residents in the home. That's a challenging thing to implement in terms of resources and the impact on residents, but our position was that that was a proportionate and necessary safe position to take. That included things like full use of PPE and the rates at which PPE is changed, etc. Again, we set that out in local and regional guidance, worked hard with providers to explain that and to offer that assurance that this was the right thing to do. National guidance, again, very quickly caught up with that. So it might not have been a huge period of time between, national guidance reflecting some of the things that we were doing local and regionally. But even if it was a few days, even if it was a week, it's still better that we were, as a region and as a council, trying to be on the front foot with some of this stuff, not just being passive, waiting to be told if things made sense to us. I've talked already about the PPE, just reflecting it has clearly had a particular impact on care homes. All of our approaches have touched on the funding already. Again, our approach to providing financial support, we've agreed that across both local authorities and the health board, so that there isn't inconsistency and then confusion and concern amongst providers as to why is it being different in one place rather than here. That concern does exist across Wales, but at least doesn't exist in our region. This is a bit of a double-edged sword. So we have maintained daily contact with care homes with our advice along the lines that I've already talked about. Probably it's fair to say that care homes felt bombarded by the amount of contact that they were getting from various different organisations, including our own. We have tried now, and it's probably been up and running for about a month now, to route everything through a regional group that we've set up. It's called the External Commissioning Group. So we've agreed with CIW, with Public Health Wales, amongst our organisations, that we'll have one place that will route comms through, information requests, etc. I think that's a lot easier for our colleagues in the external sector. It's not absolutely perfect because they still will get some stuff from elsewhere. Welsh Government, for example, still write out once a week. But the majority of stuff now is routed through that. So I'm grateful for the hard work of that group, and also to colleagues and partners in CIW and Public Health Wales that they agreed to that arrangement. This was a significant one for us. I'm sure it's something that you will come back to. So again, we early doors, not right at the beginning. but certainly as it started to emerge, in terms of discussions locally and regionally about, hang on a minute, we're seeing increased rates of infection and infection transmission within our closed setting. So we took a position of saying we need to have a design across health and social care that doesn't knowingly transfer infection into closed care settings. In practice, what that means is you would try and support people to stay at home, unless they needed absolute hospital treatment, despite the fact that they are receiving social care and other interventions, we should try and support them at home if that's safe and appropriate, rather than get them into hospital. And from a hospital, we wouldn't want to move somebody who was known to be infectious into a care home, or indeed in those circumstances back home if they were receiving social care, until we knew them, or as best as we could tell, that they weren't infectious any longer. Now, we established that arrangement early doors. Implementing that arrangement was tricky in terms of, at that stage, with the national testing regime, we were having to rely on symptomology rather than knowing for sure that people had been tested and had the results of those tests. Accepting that, and I'm sure again we'll come back to that, still establishing the principle was very important, because it has helped us design our systems, for responding then and going forward, with it being very clear that we don't want to increase risks around the system by moving infection around wherever we can avoid that. In reality, the default position is if somebody needs to be somewhere for treatment, stroke care, and is COVID infectious, well, in an emergency, the chances are they are going to find themselves in a hospital, but we would try and avoid that. Where we wouldn't put them is in another closed setting if they needed care and were infectious with COVID, given all that we've learned about the difficulties of managing infection within closed settings. Early doors, again, testing, as the arrangements for testing and the policies around testing have clearly changed significantly over the weeks and months. But very early on, there were arrangements for to begin testing of social care staff, including care home staff. There weren't huge capacity, and frankly, they didn't work very well. And it was clear to us, early doors, that they weren't working very well. And I was really pleased that the health board agreed to work with the two local authorities to establish local arrangements that we believed were an improvement on the national arrangements at that point in time. I know the health board, then had a little bit of kickback themselves around, why have you done something, different to what's starting to be agreed nationally. Again, as a region, we took the position of saying, well, this is the right thing for us to do for our residents locally. Things have changed enormously, so I'm just acknowledging that was a particular point of time. Things then, it looks nothing like that now because it's changed so completely. But still, it was good at that early stage that the region was able to respond in that way, and I'm grateful to colleagues on the health board that they supported that way of working. Subsequently, and this is much later now, once the national policy was established for the rollout of testing to all staff and residents in care homes, that was and has been completed in this region. As things stand at the moment, we're still in a period of weekly testing of care home staff as part of a national arrangement, and whenever that picks up on any concerns about infection in care homes, then all the staff and all the residents are then tested. So that's still happening at the moment. We're waiting to see what the national strategy will be going forward based on the feedback from this weekly testing at the moment. Same thing kicks in if a resident becomes ill, symptomatic, etc., or then that full testing of all of the care home will take place in those circumstances. Again, something else that we did early doors was arranged additional counselling and pastoral support. That's a combination of services offered by the Health Board and offered within the council. Obviously, you would expect strong arrangements around our in-house provision, but we extended that to the to external provision. So usually you would expect external providers to have their own arrangements. Some of them do if they're part of big national organisations. Some of the small ones don't. So I think probably the first time that in earnest that we mobilised that additional counselling support was actually to an external nursing home that was hit badly early on in the pandemic. Move on to domiciliary care. Talked already about the reprioritisation of care packages, and again, have to just remind the committee that that's a particular focus on. You do not want to risk take unnecessary risks around transmission of infection by having people in and out of homes where there is a better and safer alternative. That's not to say that every step is clearly taken to manage infection control when we are providing care very necessarily for the huge number of individuals that still require that care. It's just about limiting unnecessary risk as opposed to saying it's inherently dangerous to do that. That is a sensible and proportionate approach to take. That's still our model going forward, albeit the community arrangements and family arrangements are clearly changing as lockdown eases. So we are picking up more and more care, but clearly the level of infection in communities at the moment is lower anyway. So that makes complete sense. The other side of that coin is clearly there are some individuals who'd be used to other services, specialist day services, etc. We've had to step up the amount of care and support that's provided for those individuals at home. That's part of the reprioritisation. This point about block commissioning of domiciliary care. So we're very concerned at the beginning of the pandemic that there would be an increased risk of fragility in the domiciliary care market if providers were having to be paid on the basis of, this is the amount of care that we've provided. So we took a position of block commissioning, a month at a time in advance, domiciliary care at levels that we had pre the pandemic. The quid pro quo with providers was we expected maximum flexibility around their provision of, care. So where an individual package, needed to be flexibly delivered, that they would respond to that, and that they would pick up packages, particularly from, around moving people out of intermediate care or out of hospitals as quickly and efficiently, albeit safely, as possible. Consequences of all of that stuff is that our brokerage list, essentially our waiting list for domiciliary care, remains at 0. It might go up to 1 or 2 on any given day, but effectively it's at 0. In normal times, the best of times in Swansea, that waiting list is usually 120, and you will have heard from the head of service last year that where we had particularly difficulties last year, it rose to 180. So it's extraordinary, again, a tribute to all of those staff and the different organisations that at the moment, and in this very false, set of circumstances in which we find ourselves, waiting list of 0. That's really helpful because it does mean that we are able to be responsive to prioritising emergency circumstances at the moment. I've touched already on the use of PPE. Same applies in terms of domiciliary care. We moved at the point that we made a judgment. We're not waiting for, you know, a pronouncement that that there is sustained infection transmission. We moved to full recourse to PPE in advance of that position being taken. Hospital discharge. One of the things that we've been working on post the pandemic, but building on our hospital to home work that we've been doing, you know, been a regional priority since kind of autumn of last year, and we've done lots of work around implementation of that prior to Christmas. There's expectations, national expectations, revised guidance that said we need to have a system that can facilitate rapid hospital discharge. Logic being, you do not want anybody staying in hospital who has completed their treatment and is infection free in terms of COVID being in hospital, because hospital, like any other closed setting, is a place where you're at higher risk, frankly, of picking up COVID. So that's the logic behind the national arrangements. You absolutely accept that locally. Part of our establishing the position that says we don't want to knowingly transfer infection around the system is, well, equally, we don't want to leave people in a closed setting, whether that's hospital or residential care or intermediate care, for an unnecessary period of time. You know, we would rather support them to be at home and safe at home. So we've worked on that protocol. We have agreed the protocol now. Huge amount of system change required both within the hospital and across community services and local authority and community health. Absolute tribute to all of the staff that have worked on that. That is up and running now. That was implemented week before last. It will take about a month to generate performance information that will then be able to reflect on how well that is achieving the objectives that we've set. Anecdotal feedback is, obviously there have been some teething problems and some learning from that, but overall that's working well. We'll wait for the performance information to get some proper feedback in relation to that. In order for that to be safe and for us to properly implement the don't knowingly transfer infection, slightly ahead of the national requirement in relation to that. We actually, no, I'm misleading you there. We established the requirement not to knowingly transfer ahead of the national guidance. The requirement to test for a negative test before anybody can be discharged from hospital into social care, particularly closed settings, but this applies to all social care. That was implemented as soon as the national guidance allowed for that. The reason we couldn't go ahead of that, and just correct myself, is the testing, prioritising testing capacity required that national steer. So as and when the national steer came, then it was reprioritised to focus on this. Again, an important part of that expanding our community offer, both in the council and across the third sector, included making sure there was a designated pathway to facilitate pull from the hospital via community services as opposed to critical care services. Actually, the third sector and other bits of the council were slightly ahead of our critical care services in being able to establish and deliver against this pathway. So again, I'm really grateful to colleagues for all their work on that, and that's a real success and absolutely something we would want to see part of our future system design. And then just a nod to some of the next steps. So I've touched on already, we're in the 4-week implementation stage around the staffing restructure. That includes us needing to be absolutely clear around our arrangements that we would need to move to if we were in surge or super surge, and that would include things like a move to 7-day working that isn't needed immediately as part of adaptive, and if we stay with levels of transmission at the kind of levels we see now, wouldn't be needed, but that might look very different in the midst of winter with a combination of flu and a resurge of COVID. Well, then our forecast would be we couldn't manage things without 7-day working at that stage, so we're building those arrangements in now in advance. Touched on already, we need to review the head of service structure, see what works, what could be improved, make sure both organisations are happy that this should be a part of our preferred future. Step up on the work around our recovery and adaptive service planning, so it's not feasible to, for example, not have any respite care arrangement or planned respite care arrangements for 12 or 18 months, not feasible to have no day service offer, for example, but those offers and that service may need to look different under adaptive planning than it would necessarily pre-COVID being in our community. We do need to look at our use of offices. So I said before that we've done really well, workforce done really well around use of technology, etc. But it's not an optimal model. The reality is we are still a service that relies on relational social work practice, where the mentoring and support of staff includes being able to work alongside other people, to have people, peering over your shoulder, offering support, being able to feed, all of that kind of stuff is compromised under a model where so many staff are working from home. And however hard we try to mitigate for that virtually with teams and supervision, etc., some use of offices different to what it looked like pre-COVID, but different to home working, will have to take place. So we're working through the details of that at the moment. We need to relook at our prioritisation of care. So under, our initial prioritisation was a response to surge and what we feared would happen in terms of surge. Well, now we need to be thinking about adaptive, the long haul. What does it look like over 12 to 18 months? What would we do if we had another surge? So care won't look the same as pre-COVID, but it won't look the same as whilst we were in surge. Including within clearly the recovery and adaptive service planning is the reopening of some services, but again, they may look different to what they looked like before COVID. That's it, Chair. I'll shut up there and allow you to ask some questions.
Thank you very much, Dave. That's very comprehensive and excellent. I think I'm going to ask some questions first. If you're going to close your screen, that's great, so we can see everybody now. Brilliant. Jeff Jones has got the first question, I think. And people want to indicate if they want to ask questions as well. Jeff.
Yeah, thanks very much for that, Dave. And yes, I think it's been an experience for everybody, really. And, compliments to the staff and the health authority staff and so on. I was going to start asking with regards to the Welsh Government guidance, but I'll just leave that for the time being. But I had two particular points I actually wrote down. One was the remote virtual assessment. I know you said somebody would probably ask. And I wrote another question down with regards to reprioritising our offer of care through revised eligibility. Is there a correlation between the two parts there?
Dave?
Not particularly a correlation. So the reprioritisation of care was linked to the things I touched on in the presentation. So we knew we'd have to increase some of the care to some individuals to be able to support them at home. Otherwise, they, in these circumstances, they would, risk an escalation into more institutionalised forms of care, or potentially we could help avoid a hospital admission, or because we were closing day services, therefore, people who relied on those services might need more care at home. And the basic judgment was if for some individuals, providing more care to them at home was the safer option for them, because they would end up in potentially a more risky situation. And for some individuals, offering less care to them at home was the safer option in their circumstances, perhaps because they had less intense needs, perhaps because they had family available, etc. So it was striking a balance. That's predominantly what the reprioritisation of care was about. There was also a worry about, which I touched upon, around, oh, hang on a minute, we don't know whether actually the overall care system could be at risk of breaking down entirely. So if huge swathes of staff went off because they caught COVID, could it break down? So you had to retrench also for that reason, to make sure that we would, we were sustainable in all eventualities, when we didn't really know what the first surge was going to look like, and there were all sorts of, awful modelling predictions at that particular time. So that's really what prioritisation was about. The virtual home working was more about, well, wherever possible, we don't want to expose staff either to risk of picking up infection themselves or transmitting the infection themselves. So if you can do something virtually, so an assessment, for example, if you don't absolutely have to do that assessment face-to-face with an individual, then don't do it face-to-face, do it over Skype, telephone calls, etc. That doesn't work for direct care. Direct care clearly has to be delivered face-to-face. That's intimate care, yeah? So so when I'm talking about the virtual stuff, it's predominantly the assessments, the consultations, the advice, as opposed to direct care, which is, that's still going to be domiciliary care workers going into your house, residential care, you're getting your care there, therapy going into your house, that sort of stuff. Even some of the assessment work, frankly, has to, some of the more so probably in children than adults, but some of the assessments, you just couldn't do them safely or well enough without some face-to-face contact as well. In those circumstances, you'd be applying social distancing and all the other things that you do. Now we'll probably, again, as part of, it's not optimal to do everything virtually, so we'll now start to need planning for, well, we need to step up a bit more of the face-to-face assessment work, because it's too compromised if we're doing it all virtually, is what we're working through at the moment.
Yeah, okay, thanks for that. That's clear, that. Thank you. Okay,
Chris Holly. You're muted, Chris.
Right, yeah, I just unmuted it. Again, I have to say, I think very comprehensive presentation, Dave. Thank you very much for that. I think the one question I have is about the recovery plan and how we program that recovery plan. I think the work we've done up till now has been amazing in many cases, but I think now the recovery plan and going forward is the one that's really going to have to challenge everyone. Have you got any sort of time scale yet and who's going to be involved in that for that recovery? Thank you.
I'm gonna hand that over to the heads of service, if I may, because they are right at the centre of delivering the recovery plan, and frankly, they should be doing some work this afternoon as well.
Who's coming in? Amy first, is it? Or
yeah, okay, I'll say Helen and I between us. So the recovery plan, I think part of it is around the restructure of adult services, as Dave mentioned. So we're in a implementation phase of that. So that's going to be over the next 4 weeks. I think we've also looked at the business critical functions as well. So we'll be looking at all of those. The day services, as mentioned, but I think we're looking more around day support at this point in time, because with the social distancing requirements, the capacity of our buildings, transport requirements, the fact that a lot of our teams have been redeployed deployed at the moment into residential care. You know, all has to be looked at. So residential care is a key aspect of what we're looking at in terms of the adaptation phase rather than sort of full recovery. And then being ready to adapt to surge at any point as well. So I think we're looking at the business critical functions as mentioned, and also the restructure, so we're ready to go. I don't know if Helen wants to come in with anything.
Can I just ask Amy, before Helen comes
sure.
in, at what stage does the reprioritisation of domiciliary care become a problem? Because clearly we've effectively restructured that so that people who've been getting it are no longer getting it. We've looking upon that as a temporary measure, or is that going to be more permanent?
Do you want me to answer that,
Yeah,
Amy?
thank you.
In terms of that, that's been a very flexible situation. Really, we've had the numbers of people whose care has actually been impacted is not huge. I think out of the 97 of our internal services, only 37 people were impacted. But as part of that, and with our external provision as well, what we've been really keen to do is to keep reviewing that and monitoring that. So majority of packages of care have been cut slightly in terms of the hours or the frequency of calls, and very far fewer have been stopped altogether. The majority of packages that have been stopped have been usually at the individual's request, because they are not wanting us in their property. So it's never stood still, really. When we're contacting people, if they're struggling, if their family have been able to support, they've had to go back to work, etc., we've been reviewing those on an ongoing basis and reinstating where it's required as we've gone along the way, really. So it hasn't been a full stop and a restart, really. It's been more of an iterative sort of process, really.
And there are a number of clients who rely on the day services who have obviously not been able to have those. Have we had any impact of any assessments of the impact of the withdrawal of those services on those clients at all?
Yeah, our teams are checking in with the individuals and their families regularly. They've also got a situation where everyone's got a telephone number that they can call if there's any crisis situations. And there are a number of individuals that we have brought back into elements of the service. So we've got 4 of our day services at the moment that are running in a different way. So Gorsinan, Forest Fark, etc., 2 others as well, which have got much smaller numbers, much more on a one-to-one basis. But this is trying to support families and individuals when they're in a bit of crisis situation, I suppose, at the moment, or really requiring that support. And we're looking to see how we can phase into opening and providing a bit more, but it is going to look very different. It really is. While we're in this situation at the moment, we have to ensure first and foremost that it's safe for everybody involved in the service.
Okay. Chris, did you want to come back at all? Or?
Yeah, if I can. Why I ask about the recovery plan is because obviously the services that we provide, not the domiciliary, the daycare services and what have you. But one of the things I'm acutely aware of is that during this period, which has been horrendous for many families, especially with elderly relations who have been isolated, the problem with the daycare system has been, yes, we can phone them up occasionally or we may call into them, but I think we now need to have some sort of clarity about how we can bring them back together, if you like, for a better term, because I think there is a feeling amongst the community now that many people, psychologically they feeling, if you like, isolated. And having spoke last Friday to a number of volunteers who take food parcels around and actually do work for people in the community, there is this growing sense that we need to have, if you like, that social element back in. So, you know, I appreciate you can't give, say, a week next Friday, we're going to start doing it all. That's a fact. I understand that. To understand that may have to be a priority, and a priority that we need to look at in a very near future.
Yeah, absolutely. And I think what I would say is we are looking at alternatives as well. So it might not just be around a traditional day support service, but we're utilising direct payments where required, community response as well. So linking in with the local area coordination, the wider support and our third sector partners there as well. And also the resource support team, sort of increased support in that way. So it might be a different package of support that we're looking at. But yeah, we're certainly, I understand what you're saying.
Okay, Paxton.
Thank you, Chairman. In terms of what you've been talking about there, and prioritising our our offer of care through revised eligibility, what changes in general do you see going to become with the eligibility criteria, and how do you think they're going to affect people in that sense, and what are the main changes going to be in terms of assessments to determine what is required?
So I'll invite the head service to make any additional comments. But I suppose for me, Paxton, so if the eligibility arrangements that we agreed to respond to the crisis were based on our best guesses at what a surge might look like, all the things that I've talked about. So they reflected what we thought we had, the concerns that we thought we needed to mitigate against, and worries about, I suppose, being prepared for anything that might be thrown at us. Well, we clearly learnt a lot over the period of the last 3 months. I think now it's a twin thing. So I don't think we can return to some extent, it's a bit disingenuous to talk about eligibility. It's about making sure that we have an approach to supporting people that takes into account, like Amy and Ellen have described, that takes into account that infection is going to be, this COVID infection and risk of COVID infection is going to be with us for the time being. And there is a link then between, call it eligibility, call it whatever, our ability to find the right way of supporting people that approach us for care and support needs to reflect the fact that COVID is with us. Now, whilst it's at a fairly low rate of transmission within the communities, it doesn't necessarily, on the face of it, need to significantly impact on, the again, call it eligibility just for ease. Doesn't necessarily. The difficulty is if we don't still pay attention to it, the risk of surge and super surge increases, and then if you get back to surge and super surge, well, then it's very impactful. So I think that we haven't got all the answers at this stage. It'll emerge through the recovery planning. There will be an expectation, I think, from Welsh Government, who will say, even if you have got COVID, even if we're living with or learning to live with COVID, you still need to be applying Social Services and Wellbeing Act and the expectations of the Act. At the moment, there isn't, via the COVID legislation, there is an acceptance through that we will have to prioritise things. But all of that was shaped around, anticipated or actual disastrous impacts of COVID. Fewer staff, can't run services, can't keep people safe because can't do social distancing. That will change over time. That will impact on eligibility and numbers of people that we need to support, the ways that we are expected to support them, and the application of the Act. But I think bearing in mind just that's the consideration that's going to be in my head, certainly when, the lens through which I will explore the work of the head service and and their teams will be, how does this make us fitter for purpose to respond to support our residents with care and support needs when COVID is in the community? I think probably we kind of alluded to it, but I didn't say it clearly enough. Might come up further. There are things that we have done better, I think, for our residents as a result of COVID. So some of the ways that individuals you know, either working with colleagues in the third sector or working with people elsewhere in the council, or working with their neighbours or working with their families, have actually ended up with better supports than we perhaps would have traditionally responded with, because we had our traditional ways of providing care and support, and, you know, people engage with us on the basis of, well, this is the way you do care and support. So some of it has changed. That was really rambling, Paxton, and it's because I don't have a definite answer for you at the moment. We are working through it. I do think living with COVID in the community has to be a significant consideration, whatever that looks like. But I do expect Welsh Government to retract the COVID legislation at some point and say you have to be compliant with Social Services and Wellbeing Act. You know, that will happen, and that will impact it on as well. I don't know whether Helen or Amy, you want to say anything more coherent than I just did.
I don't think it's more coherent. I think it's just what's been really loud over the last 4 months has been the individuals, the people receiving our service. Their voice has been loud. And for me, that's been a huge game changer in the way sometimes that we've delivered services, by maybe thinking we know best, and individuals who have said to us, I don't want you in my house. They've been far more, to a degree, empowered, and we've listened to them more. And I think I think that will definitely change the conversation in terms of listening to individuals about, when we discuss their outcomes, what we're looking at and the way that we deliver them. I think it will be different. I think there's a lot of learning from this that we mustn't lose.
I think, just to back up, but for me, there's a number of strands that need to come together at some point in the near future, Dave, isn't there? So there's about that review of what worked well within the community, what worked well with the response. But the third sector and our partners as well, you know, what worked well from their perspective is going to be hugely important going forward as well, to sustain possibly a different, and as Dave has highlighted, a better model for some people living at home. So it might not, going forward, these people might not be supported wholly by the council in future, and it may be people in the third sector, and our partners. I know we had a very productive meeting last week with some of the RSLs around how local area coordination had worked, for example, and touching on some of the points about, you know, Chris mentioned about keeping that contact with people, that social interaction. So, you know, in many ways, this is an opportunity, is probably the wrong word, but out of adversity, I suppose, there's a chance to reshape some of this for the better, I think. And then I know that Helen and Amy are undertaking those pieces of work currently, and at some point in the near future, we'll be able to share those with you. So I do think it's about seizing some of the really good stuff that has taken place out of this as well, and it may well look different, and eligibility will feed into that as well at some stage.
Well, I'm hoping, and it looks like, that one of the big pluses that might come out of this is that the council and the health board will work far more closely together. Now, there's people far more qualified to talk about that in this room, and we've had our discussions about that in the past, so I'm not going to push that any further. Just a couple of other things following on from that, if I may, and it'll be very quickly, and that'll be it then, Chairman.
Okay, Paxton.
In terms of where we are now, how detailed is the information coming to you in terms of the infection rates in various elements, in various parts of the community, by postcode or whatever? And how are you seeing spikes that are requiring in you as a department to react more specifically? And if that's the case, do you have a particular team for doing that? And certainly tied in with that, of course, is the test and track system and the response times that you get in between tests being carried out and the results coming back to people, so that you know exactly where you are in that sense. So those are, I think, a couple of things currently that are quite pressing, obviously, in terms of you being able to determine where you need to be going in the short term at the moment.
Okay, I'll go first, but colleagues, feel free to step in. So we're obviously linked in with all of the testing arrangements, including the test, trace, protect arrangements, but we're not, as in adult services within the council, aren't running or delivering or overseeing those arrangements per se. Adam Hill, Deputy Chief Exec, is leading the corporate, oversight of those arrangements, and they're being facilitated predominantly through staff from linked into Martin's area and the place directorate, etc. Our link with it is we are part of the various groups, the governance arrangement. So we have representatives on those groups. I think, Helen, you might be one of our representatives on one of those groups, if I'm remembering right, but correct me if I'm wrong, and you might want to say something about this as well. From my perspective, we are getting the timely feedback, particularly around the care home stuff, because a lot of the testing at the moment is still testing that is linked to care homes. So that's what's generating a lot of the results, and then any of the contact tracing, etc. So clearly we're getting a lot of feedback around that. I think certainly from a local perspective, that our contact tracing arrangements and all of that's working, is working really well, and the Swansea element of the regional arrangement seems to be working well. The bit where there is a little bit of concern at the moment is where it links to what is now a national arrangement around testing of care home staff. There have been a few challenges to work through to make sure that works seamlessly, and that has led to some examples of some test results to some care homes taking a bit longer than we'd have hoped to come back. But there, from my perspective, unless Helen knows more up to date or differently, those appear to be the exception to me rather than the rule. So mainly the systems seem to be working okay. All of the national arrangements have taken a while to bed in and work well. That's why I touched on in the presentation, early doors, we stepped in and created some local regional arrangements. We're not at a stage where we can do that now because it's all got so big. It has to be part of the national infrastructure. So I think we are, certainly from a social care perspective, that we overall are getting timely information, and it's helping to make sure that our links and our advice to care homes in particular are going well. I haven't heard anything wider amongst the council, and I wouldn't want to talk too much about that. I don't know whether Clive wanted to comment on that. But it all seems, my impression is that stuff's working well. That stuff's working well as well, but that's not peculiar to adult services. I feel, I don't want to talk outside of my remit, I suppose, Paxton, and run any risk of misleading you. Helen, I know you're on the group one, at least one of the groups around the testing. Am I misrepresenting any of that, or is there anything you want to add to that around the care home side of things?
No, and no, you're not misrepresenting it. No, I don't have anything more than that, Dave, really. Okay, things are set to working fairly well at the moment.
I think the only reason I asked the question was whether there's anything coming through in that respect that was going to help you in future in terms where you look into plan and put your resources at a particular point in time in the short term or the medium term.
Clive,
the only bit of extra assurance, and I understand that the ask's better now, Paxton. So we are working with the health board to develop a range of indicators. One of them would be, anything that emerges from the testing, any spike things. But there's also things like, well, how many people are currently in hospital who are infectious? Where are we at with critical care capacity in the hospital? But then you also need community things. What's the number of care homes that are currently able to accept new admissions because they're not in lockdown? So we're wanting a broad suite of performance indicators that we monitor for trends, but also help us to make that judgment around, I think we might be approaching surge, therefore we might need to implement extra steps around our restructuring, or, you know, most obvious one being 7-day working or something like that. So the logic of what you're describing, absolutely, Paxton. We're building it into our performance monitoring arrangements across the region, but it's wider than just the testing bit. It'll be a suite of indicators.
Okay, Clive, did you want to add anything?
Not really. Only that Dave has articulated, I suppose, the link from a social care perspective of what would be the triggers, you know, moving into, you know, surge and super surge to localized infection. I guess that's what you were after, Paxton. And he's right in terms of Adam Hill's team. So Adam's been working to set up a Swansea test track protect team within Swansea, but that reports to both a regional and national structure in terms of managing. My understanding is, I don't know exactly, but my understanding that the numbers that have been coming through to that particular team has been quite low, really low. So there's nothing indicating at the moment that, you know, that there's the sorts of things we would expect to see, like a rise in the cases that are being dealt with by the teams, both locally and regionally, filtering through into social care. So, but those arrangements, as I say, come under the jurisdiction of Adam.
Okay, thank you, gentlemen. Appreciate the answers. Oh, and ladies as well. I'd be in trouble otherwise, wouldn't I?
Okay, Tony, do you want to come in?
Thank you, Chair. Two linked questions, if I may, please, David, and they're both to do with anticipating the future. I was saying in another context the other day that everything I'm listening to and seeing in the wider media suggests that the coming together of health and social care in new ways and better ways is almost a given. The only question is timing and how it's done. And I was wondering to what extent Swansea might be in a good position to lead that debate in terms of showing the good things that have happened here and arguing for the things that work well and support rather than the things that get in the way and build barriers. And the second part of that is, and forgive me if you've touched on this, but I've missed it. I haven't heard you comment on or express any concerns about the potential loss of capacity, care capacity in the private sector as a result of what's happened financially and organisationally. I mean, to what extent is that a risk that is lurking in the background as part of the reshaping debate?
Dave, or?
Yeah, no, thanks, Tony. So, yes, I suppose it's the short answer to yes. We're at least as well placed as the you know, to the extent to which I could describe the way we've approached things as a council, as a region. You know, innovations like the development of Helen's role are clearly, you know, at least symbolic. It's much more than symbolism, but at least symbolic of the direction of travel that we would want to take. One of the things that's happened at the moment is that I'm saying it because relevant to today, and I think to the question that you've asked. So Welsh Government last week or the week before announced that they want to do a rapid review of the approach that had been taken to supporting care homes, you know, as a significant element, you know, of the response to COVID. And we met with Professor John Bolton this morning, and we insisted on meeting with Professor Bolton as a region, because that was the approach that we had taken, you know, as I've set out and the cabinet member referenced, as opposed to the approach that he was intending to take, because that was the approach he was taking with everybody else, which was to contact each individual organisation. So we rejected that approach and met with him as a region, which he was really appreciative of, and said, well, you know, by taking this approach, we spent a couple of, you know, an hour or so with him going through a version of what we talked about today, but with, you know, even more of a partnership focus. And he said, well, look, this essentially was exactly what, you know, I and Welsh Government were looking for. How can we operate in this way, not only to respond to things like COVID, you know, have we responded in that way to COVID? And is our response overall for our residents and patients better as a result of that? We would argue yes, but clearly it's the approach that we've taken. Therefore, what are we comparing it with? He's comparing across Wales, and I think he's saying it is significant that nobody else came back and said, why don't you talk to us as a partnership? He interpreted that as significant. In hearing the feedback, he didn't say that he was hearing from us, you know, things that were completely different to elsewhere. Of course, he wouldn't have experienced that. But he did think it was a particular strength. So I think this region, as opposed to just this council, are very well placed, you know, to build on the work that we've done to date. I think it's true to say as well, for overall learning as a partnership, the reality is we have achieved more and better in the most difficult of circumstances in 3 months as a partnership than we have in 6 years as a partnership. And that's not to denigrate the 6 years worth of effort. And some of that 6 years worth of effort allowed us to work as well as we did over this last 3 months in the most terrible of circumstances, for our, you know, for our residents and for our patients. You know, so it's not inseparable, but there are lessons in there. There is something about when push comes to shove, we can do it. We can do it well. We can do it at pace. Organisations can take risks. Organisations can work across boundaries that they wouldn't instinctively work across. All of those things are demonstrably possible because we've shown that they're demonstrably possible. I think that space to do that is still an absolute imperative, and the opportunity is there for all the reasons that we've talked about today. So I definitely wouldn't anticipate that we would go backwards. Whether we realise absolutely everything that we could realise, as kind of hypothesised in your question, who knows? But I think that's the way this region will be attempting to do it. And I do think we are listened to. When we talked about preempting national guidance being, you know, I didn't stress that, and I don't want to stress that. I don't want to overplay that. I am conscious of the fact that we were a very proactive region in asking for policy to be reconsidered, asking, you know, on the basis of what we were learning locally and regionally, as opposed to sniping from the sidelines. You know, there's no place for sniping in any of this. You know, this is a tremendously difficult thing for any of us to have managed, but I do think it's beholden on all of us to absolutely encourage ourselves and everyone else to be the best that we can be. And that integrated bit, absolutely, that's an absolutely important, crucial part of it. And we can make a real difference for residents and patients if we go for that as confidently as we can. Obviously paying attention to, you know, safe and doing it well and doing it right, etc. That was really rambling, Tony. I might have strayed into politics there. Clive, rescue me.
I'm going to bring Clive in now. Yes, we've only got 5 or 10 minutes left, Clive, so we can try and get this wind up a bit. Yeah.
Listen, very, very quickly on that particular point. There's 2 aspects for me, Tony. It's supporting Dave. It's really exciting, I think, that this integrated role and this restructure that Dave has put in place. I really hope that we can lead and build on a huge amount of work that's taken place since in the last 3 months. That's the first point. There's the wider aspect, though, as well, isn't it, about not forgetting social care and the role that it's played in the coronavirus response. And there's that wider discussion then, you know, about having a sustainable social care service going forward, and how we look at the private sector and all the issues that are affecting that in terms of maybe pay conditions, terms of service for the people working in that industry, which we're really keen to lead on politically. So I know the leader is already having conversations with ministers around that, and we've got an opportunity within the rapid response document or piece of work that Dave is responding to as well. So very quickly.
Okay. Do you want any more questions, Tony? No.
I didn't answer the financial stability, did I, Tony?
Right.
So, I mean, I talked about the, you know, the estimate of, you know, £3 million we think will be the, you know, investment on top of what we would have expected to pay out to the independent sector. That takes us up to June. The detail of the ongoing scheme. So I think there's a recognition in Welsh Government, and we're certainly advising that as Directors of Social Services, look, you know, any belief that having pumped 3 million in, that the sector still, you know, is going to be okay now, that's based on a false premise, because there is a long tail to the implications of what the sector has gone through. You know, numbers of, you know, frankly, the numbers of deaths that there have been, certainly in some homes. You know, the fact that that's left them with voids, the fact that they're then not able to take other admissions, all of that stuff clearly would have had an impact, on top of the fact that their costs will have gone up because they now need to care in a different way. So all of that's it remains a real factor. I suppose balancing that with the other side of all of the remodelling that we're talking about. So do we want the sector, you know, and our approach to look exactly the same going forward anyway? Do we want to prioritise even more services around keeping people at home, you know, safe at home, as opposed to in more institutions? So a lot of that's got to play out. At this stage, yes, we are concerned about ongoing financial impact, and that's without taking into account what the Cabinet member has just said. Frankly, we haven't, as a, you know, a society, sufficiently valued and invested in the sector anyway. So that's without that additional investment. Once you factor in that as well, you know, it's debates really about, is it, you know, is it a fit for purpose model that we've been operating? You know, overall, you probably say it's not good enough. You know, within that whole system context, we ought to do better as a society, and that requires a fundamental relook at the funding model, the approach. What do we want services and sport to look like? That is a live and necessary debate, and I'm sure lots of you will be involved in it.
Okay. Tony, do you want to come back, I think, or?
Well, only just to say that I'm very impressed with the report. And I mean, in my time, West Glamorgan and health and local authority agencies had a good reputation for doing things together and working well. When that worked well, Wales seemed to work well. And I'd encourage David and his colleagues to do everything that they've got the energy and the time to do to lead the debate in Wales as to how this happens, because it's going to be a very important debate. And if we're not careful, it can be left to people of less insight, should we say.
Okay, thank you. Anybody else have any questions at all for the Director, Heads of Services, or the Cabinet member? No. So you're saying something, but you're on mute. No, okay, you don't. You're okay, right? Lovely. Well, thank you very much, everyone. It's been a very helpful and very useful session. I neglected to say at the beginning, on behalf of the committee, that we should convey our thanks to all the social services staff and the healthcare staff as well, who've done such a fantastic job, and of course the domiciliary care staff in the private sector, which we've engaged as well as part of this. It's been a really good team effort, and I think we've come through with a lot of credit, and hopefully we'll continue to be able to do so for the time being. But certainly those staff who've been committed themselves to helping in this way have been absolutely fantastic. I think our thanks need to go out to all of them as well. So thank you for that on this particular item.
Chair, before we finish, could I just make one final comment?
Of course, Clive. Yes.
I deliberately didn't make any thanks at the beginning of the presentation, because I think the presentation, I think the feedback that we've had demonstrates the amount of work that's gone into this from the social care department in the council. But I got to say a massive thank you to Dave. I've been absolutely blown away over the last 3 months since my baptism of fire into this role. So Dave, a personal thanks on behalf of myself and to Amy and Helen for the way that they've stepped up to the plate. But importantly as well is the hundreds of carers that are out there, whether they're paid or unpaid, who have had to play their role as well. So you know, don't forget care, isn't it? That's what I said in the council meeting, and I'd restate that now. But thanks to Dave, Amy, and Helen as well. And I think the presentation spoke for itself in terms of the work and commitment that they put in.
Yeah, certainly would reflect that, Clive. Thank you very much for that indeed. Okay, thank you for that. And the last item on the agenda is letters. We've got a letter to the Cabinet member from the 17th of March and the response from the Cabinet member, just for noting. And thank you everyone very much for taking part. It's been a very helpful and useful meeting. Thank you everyone. Thank you. And I've got a